Thank you very much, Theo. Hello, everyone. Little interested to hear there's some people in the US, so there's a few US references here, so hopefully they ring true with you. Chris Bain's my name. I'm a professor in digital health at Monash University in Australia in a what's called a practice professor role, so not a traditional academic role. Most of my career, though, has been in the healthcare system in our state, in quite operational roles. So the first half as a medico and the second half as a IT professional and leader of various information functions in a whole range of settings. And I've had an interest in usability ever since I did some training in it with my Masters of IT with one of Australia's experts in it in the late 90s. So I'm going to talk about UX and usability today. I'm assuming there's some UX people in the audience, some usability people, some clinicians, some IT people. So I'm not going to go over the differences between UX and usability. You should know those, but also you'll also recognise while they're different things, they also have a very inherent important relationship. So I'm going to go over, particularly from an Australian view, looking out into the world, the issue of UX and usability for electronic medical records. Briefly bring you back to some work we've started in Australia after starting around the world. Have a look at why I think we have these problems and also look at some ways that are being addressed to move forward in addressing these problems. So again, mainly for our Australian audience, mightn't be news to some in the US. So when we're talking about electronic medical records in this kind of conversation, we're talking about the kinds of systems that Cerner provide, or Epic or InterSystems or Allscripts, large corporate platforms, often called EHRs in the US, although you can debate the difference in the terminology. And this is not at all about having a bash at vendors. Okay? I don't want people to walk away with an impression. It's about trying to face up to a difficult problem. So there's a guy called John Glaser, famous healthcare CIO in the US, known to us in sort of health IT, informatics, digital health circles. He moved to Cerner just about 3 years ago, and I thought this was really telling that one of the first things he did was come out in public and make a statement like that. How are we going to finally fix the EHR usability problem? And just to situate people, I would estimate Australia is about 10 years behind on its EMR, EHR journey as a country versus the US. So we see these problems, but some are going to keep coming our way. This is now about 2 years old. It was around the time I went to the HIMSS event in 2018 in Las Vegas. But for the Australians or non-US people in the audience, a meeting was called, or a series of meetings between the ONC, which is the peak national body for health IT in America, and the CMS, which I think is a bit like the Medicare head office, if you like, in Australia, called Reducing the Burden of EHRs on Clinicians. So that's a little bit like, you know, the head of Ford and the people who bought thousands of Ford cars for their fleet, both at the same time going, oh, there's a problem with how people use our cars. So it's a very non-trivial and quite important point. And I was actually in the room when a guy called Don Rucker, who I think is still the head of the ONC, may not be, in Las Vegas, quite clearly said our two biggest problems with a national view are usability and interoperability. And that statement will resonate with us if you've been around. It's not just an American thing, but lots of the data is out of America. So this is the second, I think, of a survey they've been running in Finland every 3 or 4 years. This is, I think, the one reported in 2017, looking at particularly doctors' experiences with EHRs across the country. And we've modelled ourselves a little bit on that, and I'll come to that in a minute. But thousands of doctors were surveyed, noting no great improvement in that sort of interval period between the first and the second survey. Instead, the results indicate the existence of serious problems and deficiencies which considerably hinder the efficiency of EHR use and physicians' work, which directly talks to a suboptimal user experience and probably infers a whole bunch of usability and other problems. So it's more a evolution thing. Who's got the most EHR implementations seems to see this more. And so that's the sort of setting for us looking from Australia. Lots of things directly from HIMSS. This paper is important because one of the authors is a lady called Christine Sinsky, who I believe is also a physician and is high up in the AMA in the US, and I'll come back to that in a minute. But lots of studies showing, you know, high administrative burden on doctors, spending increasing amounts of time in the work hours working on EHRs, but also out of hours working on EHRs. Lots of factors there, but, you know, clearly the EHR and its role in their work life is an important one in all of that. And another example, this one published in Health Affairs, lots of encounters, hundreds of primary care physicians, 50% of their time was spent on desktop medicine based on EHR logs. So basically their days start to break down into only 40% of their time being facing patients. And this is in a general practice environment or primary care environment, which is a little concerning. And again, you know, it's hard to argue the EHR doesn't have a role in that, certainly. Lots of data suggesting that. So sort of why does all that matter? Why do we care? Well, and you know, we've dipped in a little in and out of hospital land and primary care land there, but across the board, doctors, especially clinicians, will and already do avoid using key systems if they don't have positive UX. Acknowledging there's lots of things that can go into that positive UX or equally detract from it pretty easily. And from a system point of view, from a government point of view, from a funder point of view, we ought to care about that if nothing else, because then the systems aren't being used to their optimal benefit. It's a bit like spending a whole bunch of money on a bridge and then because of queues on it or a toll or whatever, people don't end up using it and the whole intention was gone. And also because clinical information systems, which I use as a broad term beyond the monolithic or big EMR systems, you know, are designed to provide maximal benefits if you use the whole thing, especially EMRs. So there are fundamental interrelationships between different work roles in the system between nurses and doctors and pharmacists. And if certain people sort of avoid using the system or take shortcuts or have others use the system as their proxy, that's got potentially lots of ripple effects. But there's also this question that seems to be hanging over our heads of what are the impact of these systems on staff satisfaction and burnout and staff retention. And there's an interesting anecdote. I've never seen the picture, but I'm told there's a picture on a sign or a picture of a billboard somewhere in the US for a smaller hospital, basically saying, come to our hospital and work because we do not have an EHR. So that's a little bit concerning. Not hard to believe. I like evidence, but that's not hard to believe. So this is a survey done in the States of 14,000 physicians, looking at what's driving burnout, because this isn't a talk about burnout, but burnout is clearly a big problem in the American health workforce at the minute, especially the medical workforce. And this is sort of a rating out of 7. So number 4 on the list was, 4.5 out of 7, so fairly strongly influential. And it specifically mentions the increasing computerisation of practice, so EHRs. But it also mentions the top thing on the list, too many bureaucratic tasks and spending too many hours at work. I think if you could drill down on those things, and EHRs and their role and how they've been set up would be part of the factoring in there. So it's a bit hard in the virtual sense and distributed, but often when I do this kind of a talk in a live audience, I ask how many people have heard of ZDoggMD. Most people in Australia haven't. If you're not familiar with ZDoggMD, he does a whole bunch of funny stuff. He's actually a doctor. He's a very talented guy, but one of his famous things is this very high production value video to the tune of New York State of Mind about troubles of doctors using EHRs And you get a sense of it there from him leaning over the patient and typing on the computer. So powerful message delivered with humour, but I guess I'm just asking you to reflect on how much of a problem this must be for people to justify somebody doing that. It is actually entertaining. So if you just Google YouTube EMR rap, you'll rapidly find ZDog MD. So I guess I'm trying to paint the picture for you that, you know, in some quarters, this is shaping up as a major battleground with big impact. So the role of the EHR and a clinician's work life. And certainly if you read about what's going on in the Northern Hemisphere, it's hard not to draw that conclusion. But the issues really are global in nature. They're having a huge impact. They're in need of responses, and they're likely to get worse if we don't address them, certainly in Australia. So I think we're going to increasingly see this as a problem in Australia. Probably not as bad as the States for a few reasons, but still a problem. And some of you in the audience may not be familiar with the HIMSS MRAM scale, but basically it's a model from HIMSS, which is the biggest sort of health information body in the world. And EMR RAM is basically EMR adoption model. And there's a few variants of this, but basically it's a 0 to 7 scale reflecting the level of especially clinical IT in a given facility. And so level 7 is notionally fully digital, paperless, although we can quibble that. And level 0 is not much at all, maybe some departmental systems. And so now about 3 years ago, I'm sure the figures have changed a bit, but about 3 years ago, I saw a survey of this data from the States. There were 5,200 odd hospitals in the survey. 1,800 of them were level 6. So some of those would be quite small, isolated facilities, but nonetheless, 30% of the US hospitals were at level 6, which is one step below full automation, so highly automated. And that reflects that 10-year journey and massive investment that we haven't quite done here yet. But at the same time, Australia had only 3 level 6 hospitals. Now, if I could do those figures now, we might have 6 or 7, but that difference is not just population. It's way beyond the population difference. It's reflecting time and journey and money and investment. So, you know, I look at that and go, well, we must learn all sorts of lessons to be learned, good, bad, and otherwise, from the rollout of EMRs in these countries that are way ahead of us, or else we're pretty silly, really. And one of them is clearly this topic of user experience and usability of these systems. So, to that point, we were quite impressed, a few of us who work in what's called our UX network now in our National Digital Health Institute. I founded that. It was originally called a UX Community of Practice. We also have a clinical informatics group and several other specialist groups in this national body. And so those of us in the UX Community of Practice thought, wouldn't it be great to focus our efforts on repeating the finished survey in Australia, and then starting to do that every couple of years, given where we are in our journey. And so we've literally just done that. And a big shout out to our key partner, being Griffith Uni, and Cherie Lloyd, who's sort of led it from an academic and ethics point of view. And you can see all the other people involved in that, including myself. And it's for me, because these things are done voluntarily and need resourcing. And unfortunately, when we launched this early in the year, it was before this thing called COVID hit, so which we all know about. So you'll see on the right there, we actually relaunched it, and we've just closed it after being open for probably 4 months. We got about 500 respondents, which met our minimal targets. Like to do more, but I think is pretty good in Australia in the setting. I'd hope that we could build that up to thousands as we progress. So what you're seeing are really early figures, literally just taken off raw analyses. So we've got to be a little bit careful, but I think they start to paint an interesting picture. So you see there, 493 people agreed to participate. Of course, not all 493 complete all the questions. That's the nature of surveys. No matter that, we made this as short as possible while still allowing some comparison. You can see the age distribution. So a reasonable gender balance, although I'm bemused by 111 people wouldn't answer what the gender was. But anyway, probably a fair assumption that in that group it's still fairly split. Strong representation in the years 35 to 65. The vast majority of people probably matches to the healthcare workforce, probably reflects our mainly medical respondents. But we absolutely sent this as broadly as we could through lots of ways to all sorts of discipline groups, doctors, nurses, allied health groups, pharmacists, etc., because we wanted a holistic view and a holistic baseline. And you can see up to the top right there, the dominant states where states were stated, where people were employed, were Victoria, which is my home state, New South Wales, which is our biggest state, and Queensland. And they probably reflect the sort of pattern of EMR implementations, to be honest. So the ACT is small, the NT is small, South Australia would be next in line, Western Australia probably a bit underrepresented. But again, we made as much effort as we could to engage. So looking at the professional background a different way, vast majority were medical people, not non-trivial number of nurses, allied health and pharmacy. So that sort of reflects what you saw on that previous slide as well. So you know, reassurance we were getting to the right places, and maybe in a non-COVID time we'd have more numbers in each of those groups. So this is just interesting. I've plucked out, and this is very selective, so we need to wait and see what this whole analysis shows us. I mean, my hypothesis is that even now with fewer EMR implementations, some of the problems are universal because the systems are universal. We're using effectively American products in some cases. They're not specifically rebuilt for Australia. And whilst there are some different drivers in the US, for instance, it's foolish, I think, to expect that we will have no usability problems. That's just silly and doesn't talk to a knowledge of complex IT. So if we look at hospital doctors, who are probably the single biggest definable group across the country who responded, 136, there are also 77 doctors from primary and community care, and then the other groups and other settings. We look at a fundamental question that mapped to the Finnish survey. It is easy to understand, to obtain necessary patient information using the EHR system. Hospital doctors are 1.5 times more likely to disagree with that statement than to agree with it. I thought the next one was really interesting. Learning to use the EHR system does not require a lot of training. Almost 5 times more likely to disagree with that statement, suggesting that learning the system is a significant problem for this group. And something a bit more generic, the arrangement of fields and functions is logical on the computer screen, almost 2.5 times more likely to disagree with that. So those sort of findings start to point to the same space that we're observing from other countries. Early days, though. So we're in the middle of doing the full analysis and getting this published. So the interesting part, I suppose, then is why are we at this place and what are we going to do about it? So I'm going to sort of pick up the pace a bit and maybe stop a little after 10. Don't want to kill off question time. Some people literally say it's all because of US billing requirements. In other words, there's too many data fields and too much documentation put onto frontline clinical staff. And that's why there are all these problems in other countries, in the US in particular. Or it's because these systems are glorified billing systems. Sort of true, but again, dismissive and not helpful. Trying to fix the problem, you need to understand it in a bit more detail. So healthcare is complex. I do try to be really respectful of other people's industries and professions. I've never worked in another industry, so I have to be a little bit careful. But I think common wisdom is healthcare is complex, and I can talk through examples if people want to debate that. And it is luckily tied to science, but if you think of that in a design sense, a modern design of apps, that sort of works against concepts like frictionless design, and I can give you examples later. So we could put more frictionless design into EMR products and accordingly make them very unsafe and not compliant with legislation. We also have some truisms, and I see how all these truisms have played out. So every system is perfectly designed to deliver the outcome that it does. I think that's a John Berwick quote. that plays into, well, did we design it a particular way? Did we use user-centered design? If we did it, then maybe we got what we have done, intentionally or otherwise. You get the behaviour incentivised. This is absolutely true of people spending the money on the systems. So understandably, the vendors respond to what the market wants to pay for. And that's not usability. That's not highlighted, it's not thought of, it's not understood. I'd also argue you cannot manage what you do not measure. So people don't build in usability goals into the systems or into their implementation. They won't do baseline measurements. They won't see that as achieved that or not. They won't track it over time, etc. I mean, I think we also have an interesting phenomenon where people inside some institutions are, on one hand, users of the system, but they're also, understandably, because they're human, have a vested interest in the system being seen as successful, especially if you're going to spend 50 million Australian dollars. So I, as an individual, think this system is usable, therefore it is. Well, you know, your workflow might be one of 100 workflows in the system. Your user group might be one of 10 definable user groups. You can't generalise, especially if you're not measuring. I'd also argue, and I think this gets overlooked, that healthcare is also a continually evolving space. So the boundaries are constantly being pushed. And IT in paradox does not work on mass customisation. It works on abstraction and standardisation. And this is fundamentally underpinning these problems, I think. So if we consider a contrast with banking, I've said this a lot, so I actually thought I'd better back this up with some data. Again, in a live audience, I say to people, how many banking institutes do we have in Melbourne? Or anywhere for that matter, and people sort of mumble, and of course they can't think of one. And then I say, well, how many medical research institutes do we have in Melbourne, or just at my university? And there are dozens and dozens and dozens. So just to reiterate this, and I'll get to the point in a second, I did last week a Google search using Banking Research Institute. I got back 322 million results, but the top results, without me geographically constraining, Dakar, Iran, Ghana, nowhere in Australia, nowhere in my city. But contrast that to Medical Research Institute, I got 5 times as many results, and the first 3 ones are all in my city, and I could add 20 to that. Right? So it's just to highlight the point that the nature of medicine, because of its scientific underpinnings, and the same applies to nursing and other disciplines, I don't mean to be just medically specific, is it is being actively pushed every single day by thousands of people in divergent directions to follow the need and follow the science. And when you bring that back into the healthcare setting, we've ended up, for instance, if you just look at an orthopaedic surgeon, orthopaedic surgeons aren't orthopaedic surgeons anymore. Some just do hands, some just do knees, some just do hips. And while there's lots of similarity there, they're different jobs. And if you tried to build a computing system for them from the ground up, tailored to each of their jobs, you might be surprised at the differences. So this phenomenon is going on all the time, and it plays out in day-to-day healthcare as well, in what clinicians need and are interested in and are trying to respond to. And I think it's something that we overlook. So what can we do about all this? So these things are from the US AMA. So the US AMA are so concerned about the problem of doctor burnout, whilst acknowledging it in lots of dimensions. It's not just about EHR. They have put in a program called Steps Forward, and you easily find this on the web. One of the modules, there's probably a couple of modules relevant to EHRs, but one of the modules is just about EHRs. And so they've, put in very practical steps and tips and tools for people. These ones here are really focused around primary care, consulting type care rather than hospital care. But you can see there, if you read things like the idea of team documentation, so different groups in a care team, some of whom maybe never used an EHR before, actually taking responsibility for some of the documentation burden, and this overlay also of expanded rooming and discharge protocols. So that means, for instance, The practice nurse does the initial assessment on the patient, records it in the EMR. The doctor walks in, decides what's wrong, leaves, does their little bit. The nurse comes in and actions it, So in a way, what they're doing is retrofitting workflow to how the systems work. But through practical need, that's what they've done. Obviously, that's not a good thing to have to happen, but that's what. Quickly mention Sutter Health, because some of the things I'll show in a minute I think are actually from Sutter. This is now 7 years ago, but they had a huge public disaster with the EHR system. But some of these statistics I think are either exemplars of Sutter itself or what they're doing. So this is looking at system usage in an EHR in a lot of detail. And I think it says some really interesting things. I won't dwell on this particular dashboard, but you get the impression as you look at these that there's lots of dashboards now and pieces of information where either the users themselves or super users or people running the system can actually drill down in an awful lot of detail about how people use the system, and it sheds light on maybe both problems and solutions. So if you look at that, each of these graphs now are the average usage, both in terms of which system parts and the time of day for an individual clinician over a month. So just look at the breadth of those colours. The top one says that particular clinician is really only using the system between 6 a.m. and 6 p.m. Fantastic. The one down the bottom, sometimes in the month, is using it at any time of the day, including overnight. Not much, but some, and they shouldn't be doing it at all, potentially. And you can see the colours delineate what kinds of functionality people are using. So the blue is the notes. I think that implies clinically recording what you're doing. The light blue is an in-basket. So, messages coming into the doctor's in-basket. And they get a scribe, for instance, to address those on the doctor's behalf, right? So some really interesting capabilities then to get into the nitty-gritty of this usability issue. Some of you may not have heard of FHIR. I'm talking more down the solution path here. FHIR is really about data interoperability in healthcare, but it's opened a window into improving usability, and it's doing that by enabling apps. And this is from a report out of Harvard, which I think is really valuable, especially for the graphics. And if you look at the one down the bottom on the left there, for instance, the grey is like the traditional EHR is the before picture in a beauty photo, right? Dull and grey. But basically the picture being created here is increasingly by using smart on fire apps that can be deployed from within systems like Cerner and Epic and InterSystems. They've all supported this. They've all provided infrastructure to do this. You can see how in that left picture, the two different doctor users and they get some basic supported functionality across the EHR like everybody does, but they can tailor that by deploying or accessing particular apps that better suit their needs and their workflow. And you should be able to immediately see how that is one way to potentially address some of their usability and user experience concerns. I won't dwell on these examples. They're really excellent examples. If you look up things like App Store and Cerner or App Store and Epic, or I think Epic calls it, you'll get the sense from a usability point of view and a user experience point of view how this paradigm might help. So I'm just going to wrap up the last couple of slides. We've got time for questions. Other things I think education's really vital. Most doctors have got no idea what usability is. They think they know what it is, but they don't. And that's, to be fair, they've never been taught about it. And I think it helps them to know. So the MEALS acronym, memorability, efficiency, errors, learnability, satisfaction is very valuable. Pointing them to, and people in the systems inside the hospitals to Nielsen and Schneiderman's heuristics, to things like the class organisation and their analyses. I think another big problem is healthcare processes have just evolved. So if I take a really simple example like prescribing a Panadol, do people in healthcare know, say in a hospital setting on a ward, how long it should take them to prescribe a Panadol? or on average? And the answer is they don't. They just do it. And yet when we then put them in an electronic workflow, they will rapidly develop an expectation that this is taking too long. But there's been no sort of thought about what the old was versus the new, and I don't think that helps with the problem. Obviously, the whole approach to where you get to do this, right, where you're not just buying something off the shelf and stuff with it, rethinking how we develop these systems, things like personas. I think requesting usability. So when you put in a system, we buy it, what are your usability goals? How long should it take you to do certain key tasks? And if the system can't do that for you, surely that's a problem if it's that important to you. Rewarding usability and those goals in how we evaluate systems and how we award tenders. So basically thinking of usability at every stage in a system lifecycle, be it purchase or development. And then measuring it. So again, most doctors and nurses don't know about things like the SUS or the NASA TLX. Certainly learn from places like Sutter. That example I think is powerful. And also I think people need to acknowledge, there's a lot of specialist knowledge in this area. Usability is a thing. It's not just, how easy it is to use. I actually challenge audiences live to say, what is usability without saying easy to use? And most people can't. So I think, when you're trying to deal with this thorny problem, we need better knowledge right across the system. I'm sorry if I've rambled on too quickly. I hope that's all made sense, and I'm happy to answer some questions if that's valuable.
Thank you so much for that, Chris. Really appreciate it. Very insightful talk there. So I just have two questions. And the first one would be, would there be a standard sort of EHR system throughout hospitals globally? Or do you think, in your opinion, it would be sort of country specific?
We'll never have a standard EHR system globally. That horse is not bolted. We can't even get a standard one in our state. I just think that, it's a marketplace and the people paying the money are looking for certain things, and the best profile of those things will determine how the money is spent. I think when it comes to usability, and also I'd argue that's not necessarily the answer, right? I think that's overly simplistic. So I think when it comes to usability, you're making sure it and user experience are foremost in people's minds. We need to have that conversation as part of why we buy certain systems or why we support certain systems.
Okay, great stuff. And then something that I've been thinking about quite a bit, and I don't know if you'll be able to sort of answer this. Just how do you think blockchain will play out within a healthcare environment, or sort of regarding interoperability and data? Is that something we should be looking at as user practitioners, or?
The link is tenuous. I think the place blockchain will have a role in healthcare. There's a few very narrow use cases. So one that's made sense to me is in things like, payment trails, in things like more in underdeveloped countries, problems with verifying the true nature of drugs. So supply chain, both for drugs and other healthcare consumables and items. I think there's an interesting conversation about blockchain in consent models in healthcare. But I don't think there's a real direct role between EHR and usability and blockchain.
Okay, great stuff. Thank you so much. I'm just going to open it up for about a couple of minutes. If anybody has any questions for Chris, we'll just hang on for about 5 minutes so you can pump your questions through. Thank you. Oh, sorry, Sarah. I can see there I think it's my volume that's down. I'll just increase it a bit. Chris, is it okay if we make your slides available to the audience?
Yeah, like I say, Theo, I just want to add in a few references, but once I've done that, I'll reshare it with you and you can disseminate it. Okay,
that's great stuff. Look, I think we're pretty much done with regards to question time. I see one's just popped up now, and it's from David. And his question is, as a user UX designer working in healthcare, one of the biggest challenges is trying to convince clinicians and stakeholders to take part in discovery and usability testing. What advice would you give?
Yeah, look, again, without making a long discourse, I suspect there's two aspects to that. One is time, right? So, and this is a problem even for people like me who've worked inside the system, getting access to people. So on one hand, they complain if the systems don't work. On the other hand, you say, well, the process to help that is you guys work with us. And that's a universal problem. So there's lots of little tricks about trying to get access to clinicians and influencers amongst clinicians and finding internal clinician champions who will prioritise your access. But you need more than them to do this properly. The other part to that, though, I think is back to what I said before. They don't really understand. You know, the average, lots of clinicians are very savvy around IT, but it's not the same as being trained in IT and working in IT all the time. So on one level, even, you know, what's under the black box of what they use, they don't understand, let alone concepts further buried in the, you know, the teaching of IT, like usability and user experience. So I think there's a lot of education has to happen. Lots and lots of education over and over again. And I think the onus on the people in this community is to, and it's not easy, I'm not saying it's easy, but it's to do the sort of things we're doing with this survey. You've got to come up with more data that either defines the problems or shows how working with a UX designer or following a particular approach gives a better outcome, because they're evidence people, right? Especially when they're stressed and busy. One of the few things they'll respond to is evidence.
Okay, great stuff. Thank you so much. And I do see Sarah just made a comment there on the right-hand side. It's just, she mentioned that it's fantastic talk. Thank you so much. And she's currently designing for EHR systems.
Yes.
And your talk was extremely helpful. So thank you so much for that.
No worries.
Okay, great. Thank you so much, Chris.